Arthroscopic Hill-Sachs grafting with Talus allograft. Our authors do have some disclosures, although none are directly relevant to this study. Initial workup for any patient with suspected shoulder instability should include a thorough history and physical examination. In most cases, patients report experiencing a dislocation event caused by trauma to an abducted and externally rotated shoulder. A detailed exam of the appearance, range of motion, strength, and neurovascular status of the affected extremity should be conducted and compared to the contralateral side. Providers should test for apprehension and evidence of baseline hyperlaxity. Standard shoulder radiographs are obtained which demonstrate the presence of a Hill-Sachs lesion involving the posterolateral humeral head. A CT scan is then performed in order to quantify the extent of the Hill-Sachs lesion and determine whether it is an on-track or off-track lesion. A diagnostic arthroscopy is executed first. Attention is then turned to the Hill-Sachs lesion. The anterior portal is the viewing portal, and the posterior portal is the working portal. A chondroplasty is performed to debride the edges of the defect. The posterior portal is lengthened to accommodate instrumentation and placement of our plugs. Radiofrequency ablation is used to clear any soft tissue that could be interposed. Sizers are used to measure the width and height of the recipient defect to determine the size of the plugs to be used. A drill tip guide pin is placed through the sizer into the bone while staying directly perpendicular to the humeral head. Great care should be taken to ensure that a plug placed in this trajectory will recreate the native contour of the humeral head. To ensure maintenance of this trajectory during plug placement, the angle of the pin is drawn on the skin. A reamer is chosen based on the size of the plug to be used. The socket is reamed to the appropriate depth to reach subchondral bone. The bone plug is procured from the fresh articular allograft talus on the back table. The plug is brought through the posterior incision and impacted into the reamed socket. This process is repeated if a second bone plug is required. When two bone plugs are required, the inferior plug is performed first, as the superior plug can often obscure visualization of the inferior aspect of the defect. At this point, the construct is viewed through the anterior and posterior portals, and an assessment is made on the congruency of the humeral head and the overall coverage of the defect. The shoulder is drained, the portal sites are closed in the usual sterile fashion, and a sterile dressing is applied. The patient is placed in an abduction sling and taken to the recovery room. Postoperatively, the patient is started in a standard anterior instability rehabilitation protocol. From 0 to 4 weeks post-op, patients are limited to pendulum exercises only. From weeks 4 to 10, external rotation is allowed to 40 degrees and slowly progressed to 60 degrees. The sling is discontinued at 6 weeks and active range of motion is initiated. At week 10, full range of motion and strengthening is permitted. Provided full strength and range of motion is achieved, patients may return to non-contact sports at 3 months, followed by full contact at 6 months. Advantages of this technique include 1. Osteochondral allograft recreates native humeral head anatomy without altering the biomechanics of the glenohumeral joint. 2. The use of the Oates technique instead of a size-matched en-bloc graft facilitates a minimally invasive all-arthroscopic approach. 3. Talus osteochondral allograft offers a robust, highly congruent source of graft for treatment of humeral head defects. And finally, this technique does not require any hardware for fixation.